Alright, Ninja Nerds, in this video we're going to talk about diabetic ketoacidosis and hyperglycemic hyperosmolar syndrome, which are acute complications of diabetes. Alright, so the first thing we have to talk about is the causes of DKA and HHS. Now, I want you to remember these by the basic mnemonic here, kind of like a tool that you can utilize is the 6 I's. Now, those 6 I's come down to two big overarching themes. One of the themes is that there's a decreased insulin supply. So there's an insulin deficiency. And what kind of individuals would an insulin deficiency be a problem? An insulin deficiency would be a problem in an undiagnosed diabetic. Doesn't know that they have diabetes, so they're not taking insulin. That could be one reason. Or it could be a diabetic who's not taking their insulin. They're not compliant with their insulin. Or they're not taking enough of their insulin. That's one of the I's. All the other I's, the other remaining 5 I's that I want you to remember are associated with this point, where there's an increased insulin demand. And more specifically, there's some stress in the body that's causing an increased insulin demand. And I'll explain that in the later, okay? Now, the 5 I's are going to be infections. And this is high yield because this is the most common cause for increased insulin demand. Now, what are some of the infections that are associated with this? One is called pneumonia. The other one is going to be urinary tract infections. So cystitis, pyelonephritis, and infections of the skin like cellulitis. The next thing is inflammatory conditions of multiple tissues in the body, which could also be types of infections, such as inflammation of the pancreas called pancreatitis. Or inflammation of the gallbladder. Inflammation of the gallbladder is called cholecystitis. The other thing that I want you to remember is intoxication. Maybe someone's drinking too much alcohol. That could be a trigger. So someone's drinking a little bit too much rosé, right? So if there's increased alcohol. Now, not only if there's increased alcohol, but what if someone is actually taking certain types of toxins? We got a toxin symbol here. Like what? Maybe cocaine. Or other types of medications like methamphetamines. Okay? So this could be things like sympathomimetic drugs like ADHD medications. The next thing is I want you to remember infarction. Infarction, I want you to remember 2 particular organs that can create this increased insulin demand. One is an acute myocardial infarction, so some type of infarction of the cardiac tissue, or an infarction of the cerebral tissue, so a cerebral vascular accident or a stroke. The last I that I want you to remember is iatrogenic, which is mean it was caused by the practitioner. And sometimes this could be because we give a particular drug. Steroids, so corticosteroids, these are a big one because corticosteroids increase our blood glucose levels, which increases insulin demand. And the other thing is surgery. Surgery requires wound healing, and that requires glucose, and sometimes that can also cause problems as well, and just generate stress on the body. So we know the 6 I's that are responsible for DKA or HHS. Insulin deficiency, infection, inflammation, intoxication, infarction, and iatrogenic effects. The insulin deficiency part, it can lead to a specific pathological mechanism. Now, how is this happening? Now remember, whenever there's decreased insulin in the situations that we talked about, remember from the diabetes lecture, that means that we can't get glucose into our cells. If we can't get glucose into our cells, what happens to the ATP production? It starts to drop. What does our body start doing? It starts tapping into the secondary fuel sources. What's that secondary fuel source? Triglycerides. Now, triglycerides are in adipose tissue. And whenever adipose tissue is broken down, like the triglycerides in the adipose tissue is broken down, it's called lipolysis. And we break the triglycerides down into what's called free fatty acids, and there's also glycerol. Now, these free fatty acids, what happens to them is that they then get converted into acetyl-CoA. What's called beta oxidation. We break down the free fatty acids into 2 carbon chains, push it into acetyl-CoA. Whenever you have increased beta oxidation, you get increased acetyl-CoA production. Now, acetyl-CoA wants to go into what's called the Krebs cycle. But Whenever there's so much of this acetyl-CoA, the Krebs cycle gets saturated. So it starts shifting the acetyl-CoA into another metabolic pathway, which is synthesizing ketone bodies. And whenever we convert acetyl-CoA into ketone bodies, it's called ketogenesis. Now, the problem with this is that these ketone bodies, like acetoacetate and beta-hydroxybutyrate, can get into the bloodstream. When these guys get into the bloodstream, they have the ability to release protons. And when they release protons, that makes the blood more acidic and causes acidosis. But a more specific type of acidosis that's important to remember here called ketoacidosis. The next thing I want to remember, because it's going to come up in a little bit here, is that one of the ketone bodies called acetoacetate can actually get broken down. And when it gets broken down, it releases a particular molecule called acetone. And the important thing about acetone is he can get sent to the lungs, and then from the lungs, he can get exhaled out. That comes into play a little bit later. That's one aspect, and that's coming from the insulin deficiency. The other part is the increased stress. That's the infection, the inflammation, the infarction, the iatrogenic effect, and intoxication. These cause stress on the body. That stress stimulates our sympathetic nervous system. What does the sympathetic nervous system release? What kind of neurotransmitters? Epinephrine, norepinephrine. And epinephrine and norepinephrine, these two actually stimulate glucagon production by the pancreatic alpha cells. Now, with increased epinephrine, norepinephrine, and glucagon, they love to act onto the liver. When they go to the liver, they promote two processes which is high yield. Gluconeogenesis, which is where I can take amino acids, I can take glycerol, and I can take lactic acid and convert it into glucose. The other mechanism that it can promote is called glycogenolysis. And glycogenolysis is where we take glycogen, a big storage part of glucose, and break it down into small glucose molecules. That's called glycogenolysis. But guess what else it can do? It can also take this epinephrine and norepinephrine and glucagon. It can also generate the lipolysis mechanism, which can generate everything we talked about here. Now, let's go back to this high glucose. Whenever there's elevated levels of glucose, remember what we said it does in the kidney? It gets filtered into the PCT. The PCT can't deal with all that large volume of glucose, and so because of it, it can't reabsorb it, and a lot of that glucose gets lost into the urine. Well, when glucose gets lost into the urine, what does it draw with it? Water. And as we draw water out into the urine, what is that process called? Osmotic diuresis, and also can pull sodium with it too, which will come in later. As we just diurese tons of water and sodium out into the urine, what can that lead to? Dehydration. The next thing is, as you have this excessive osmotic diuresis, what does that mean? That means you're decreasing the water concentration, right? As you decrease water concentration in the blood, that means that all you're going to have is little water in the blood and tons of this glucose. Tons of glucose in the blood with very little water is referred to as a hyperosmolar state, and this is high yield. The last part that I want to talk about relevant to this is we have three components here that we basically encompassed: ketoacidosis, dehydration, and hyperosmolarity. And that's what we see responsible for DKA and HHS. But more particularly for your exams, DKA is more particularly seen with symptoms that are responsible from ketoacidosis and dehydration and variable hyperosmolarity. But for exams, remember these two. The next thing is DKA occurs more acutely, usually with an onset less than a day. And for your exams, remember it is most common in type 1 diabetics because of that insulin deficiency. Hyperglycemic hyperosmolar syndrome, on the other hand, we primarily see these two effects: dehydration and hyperosmolarity. On top of that, usually the onset comes on a little bit more than a day in time. And on top of that, this is more commonly seen, high yield here, with type 2 diabetes mellitus. Why do they not have as much of the ketoacidosis? Because in type 2 diabetics, you still can produce a little bit of insulin. So if you can produce a little bit of insulin, there's not going to be as much ketoacidosis. All right, so now that we understand the three big things that happens with DKA and HHS, now the first let's focus on is these ketone bodies. How can these ketone bodies that we generate lead to particular clinical manifestations? Well, you guys remember that ketone bodies, they can act on a particular area in the actual brainstem called the chemotrigger zone. And they can stimulate the chemotrigger zone whenever they're in high concentrations. The chemotrigger zone is in an area of the medulla near the area postrema, and that stimulates what's called the emetic center in the medulla. The emetic center in the medulla will then trigger a reflex that causes some nausea-like sensation and more particularly vomiting. That's one of the things that you might see in those with elevated ketone bodies, particularly DKA patients. The other thing is ketone bodies, remember, these are things like they're acids, they're ketoacids, so they can give off protons. Whenever they give off protons, the problem with this is that this causes an acidosis. Now, in acid states, whenever there's high level of protons in the extracellular fluid, and here we have a cell and it's intracellular fluid, what happens is the protons want to move because they're in so much concentration here in the extracellular fluid, they want to move into the intracellular fluid. So what happens is the protons move from the extracellular fluid into the intracellular fluid. But in response to that, our body takes potassium and pushes potassium out for every proton that comes in. So now potassium is going to start accumulating in the extracellular fluid because of the acidosis. The other thing that you want to remember, you know in every cell you have sodium-potassium ATPases. They pump 3 sodium out of the cell and 2 potassium into the cell. These pumps are driven by insulin. So in individuals who are insulin deficient, can they stimulate these pumps? No. If they can't stimulate the pumps, can you push potassium into the cell? No. So what happens? The potassium starts building up into the extracellular fluid. Now that means that there's a net movement of potassium from the inside of the cell to the outside of the cell. What's the problem with that? This is happening in so many cells of the body that it leads to a decrease in the total body potassium. But because a lot of this potassium can end up in the blood, you might get either normal or possibly elevated serum potassium called hyperkalemia. What's the problem with these? Whenever there's hyperkalemia or hypokalemia, whenever there's decreased total body potassium and high serum potassium, this can create arrhythmias. Now, arrhythmias might present with symptoms of palpitations or chest pain. Another thing is as you decrease total body potassium, this can alter the peristaltic activity in the small intestine. If you alter the peristaltic activity into the small intestine, this can lead to an ileus where there's no peristaltic contraction in that area of the small intestine. And because of that, this can lead to abdominal pain. Now, that's one aspect. The next thing is whenever there's increased protons in the blood, these create acidic environments. That stimulates peripheral chemoreceptors. Remember these? They're located in the aortic bodies and the carotid bodies, and they're connected to the vagus and glossopharyngeal nerve. Whenever it's stimulated, it sends these impulses on the vagus nerve and glossopharyngeal nerve to the central nervous system. And that creates a reflex that tries to increase respiratory rate. Why? Because if we increase respiratory rate, the thought is that that's going to help us to breathe more CO2 out of the body. And if we drop CO2, we get rid of some of that acid, because that's the problem, is acidosis. But in attempts of doing this, this creates a pathological sign, which is extremely high yield, which is when someone has deep and rapid respirations called Kussmaul's respiration. The other thing is not only are you trying to breathe off CO2 to try to bring the pH back up, but you're also breathing off that acetone from the acetoacetate. Remember that ketone body that breaks down into acetone? This acetone, as you breathe it off, it gives off a particular smell or odor, which we call a fruity breath odor. And this is extremely high yield as well. The last thing I want to talk about with the ketone bodies is that ketone bodies can do what's called increasing the anion gap. Now, some of you might know that anion gap is defined as whenever you take the sodium minus the chloride plus the bicarb. But you know there's another formula for this? It's when you take the unmeasured anions minus the unmeasured cations. Well, guess what a ketone body is? It's an unmeasured anion. So if I have an increased number of unmeasured anions, I take a large number, subtract it by a small number, what happens to my anion gap? It goes up. And on top of that, I have an acidic environment. This is called hagma. So whenever someone has a high anion gap and acidosis due to a metabolic issue, they call this high anion gap metabolic acidosis. The next thing is that we have to talk about is dehydration, which we see in both DKA and hyperglycemic hyperosmolar syndrome. Now the DKA, you primarily see ketoacidosis, right? Now dehydration, what happens and why is this? Because we started to pee off lots of water. Now as we pee off lots of water, that causes this dehydration. Now dehydration can present in two particular physical exam findings. One is decreased skin turgor. So whenever we pull on their skin, it doesn't return back to its normal position as quickly. The other thing is that their mucous membranes will appear dry. So you'll look in their mouth and it'll really start to look dry in appearance. The next thing is as you become dehydrated, the total volume of blood, because of us losing the water, drops. As you drop blood volume, what do we say is directly proportional? An increase in blood volume causes an increase in blood pressure, right? Well, and in the same way, a drop in blood volume causes a drop in blood pressure, and this can cause hypotension. The other thing is if we're not getting enough blood perfusing particular organs like the kidneys, this can lead to decreased renal perfusion, and that can lead to decreased urine output. Okay, that's important. The next thing is whenever your blood volume drops, remember those receptors, the aortic sinus and the carotid sinus, which are located in the aorta and in the bifurcation of the common carotid arteries. They detect drops in blood volume, but more particularly related to blood pressure. When blood volume drops, blood pressure drops, that stimulates these baroreceptors. They send signals to your central nervous system. Your central nervous system becomes activated, and it basically activates the cardiac acceleratory center and increases your heart rate. And this is called reflex tachycardia. The other thing is whenever you have increased sympathetic activity, this starts acting on your sweat glands and increasing your sweat production. And this can lead to diaphoresis. The last thing that we have to talk about is the hyperosmolarity. And this is primarily something that we see in HHS, right? Now, hyperosmolarity, how did we classify that? Whenever there's tons and tons of glucose in the blood, but very, very little water because we're peeing a lot of that out. So what that means is in the blood, it's really hyperosmolar. Tons of glucose, very little water. Now, as this blood is flowing through particular tissues such as the brain or our central nervous system, let's say, right? So brain and spinal cord, or maybe muscles. The water inside of the cells of the neurons in the brain or spinal cord and the actual water inside of the muscle cells sees all this high glucose in the blood as it's passing through these tissues. And it says, I see lots of glucose. I gotta go to where the glucose is. So the water starts rushing out of the cells of the brain and the spinal cord neurons and out of these muscle cells. That draws water out of these cells and into the blood. By doing that, you shrink these cells. Now, if you shrink the cells of the central nervous system, that ain't good. And what can happen is this can cause an altered mental status where they start to become confused. They start to become really lethargic. Then, over time, if it continues to get worse and not treated, it can then progress to seizures. And then worst case scenario, they go into a coma. The other thing is if it pulls water out of these muscle cells, it can cause problems with the muscle cells where they're not going to function properly, and this can lead to weakness. All right, so the next thing we have to do, and this is extremely important, is figure out the labs for DKA and HHS. So remember this, start off with a CBC, a CMP. A CMP is going to give you your kidney and liver function. Let's check an ABG, which is going to tell us our acid-base status. Well, let's get a UA, ketones, a serum osmolality, and then we can add on a 12-lead EKG depending upon their potassium and their age and comorbidities. So let's say that we do that and we get some of these things that we really want to focus on here. The first thing is checking their glucose, which is going to be in milligrams per DL. Now in DKA, I want you to remember that this is generally greater than 250 milligrams per DL, while as in HHS, it's super high, greater than 600 milligrams per DL. Why is this? Because they both cause hyperglycemia. DKA, remember we said that this is more common in type 1 diabetics, which are usually more commonly younger. Younger individuals might have better kidneys, so they might be able to get rid of some of that excess glucose is the thought behind that, and that might be why their glucose is a little bit lower, okay? pH, well remember, DKA is the one that has the ketoacidosis, so that pH we expect to be low. Anything less than 7.3, and it can get much lower. With HHS, it doesn't cause that much ketoacidosis. It shouldn't cause very much ketosis at all. So because of that, their pH should be greater than 7.3. Bicarb, well remember, go back to this concept down here. Remember, CO2 plus water yields carbonic acid, which gets broken down into protons and bicarb. Remember what the ketones are doing. They're increasing protons. As you increase the protons, what's going to happen with this bicarb? The bicarb is going to have to combine with the protons so that we can make carbonic acid. So if we utilize bicarb to make carbonic acid, what happens with the bicarb concentration in those with ketoacidosis? It should drop. And we say that when it's less than 18, we can consider that with the DKA. But again, we shouldn't see much ketosis or ketoacidosis with HHS. So that bicarb should be greater than 18. Not bad, right? Urine serum ketones. We're going to make this super simple. DKA, ketone production, a lot of it. So you're going to expect for this to be positive and potentially elevated ketones in the urine and in their blood. With HHS, let's make it simple. It should be negative, but if we really want it to be specific, it's going to be a very small production, not enough for it to be considered abnormal. Anion gap. Now remember, in those with DKA, they produce those ketone bodies. That increases the unmeasured anions. That increases the anion gap. So because of that, their anion gap is going to be greater than 12. In HHS, there's not that much ketone body production because they can still make a little bit of insulin because they're type 2 diabetics generally. If that's the case, then there's not going to be as much ketoacidosis and not much effect on that anion gap. So their anion gap is going to be less than 12. The last thing is serum osmolality. With DKA, they can have hyperglycemia, but depending on this case-by-case basis, it can be variable. There can be times where this serum osmolality can be normal and it can be super high. What's more high yield is HHS, Hyperglycemic Hyperosmolar. They should have a super high osmolarity, greater than 320. All right, so the next thing we have to know is, okay, we treat the underlying disease. Well, remember, they're dehydrated. Let's get them fluid. So really the regimen that they say is, let's start off with what's called normal saline. And there's a type called 0.9% normal saline. We're going to refer to this as normal saline. And what we're going to do is we're going to start off with 1, maybe 2 liters of that normal saline, and let's do it over an hour. Then what we're going to do is we're going to recheck their sodium and glucose, particularly the corrected sodium. Let's say that we check their sodium and their corrected sodium is low. Well, then if their corrected sodium is low, I don't want to go ahead and give them a lower amount of that saline, the normal saline. So what I'm going to do is I'm going to keep that normal saline, the 0.9%, and I'm just going to go with 250 to 500 cc's per hour. And then what I'll do is after I do that, I'll recheck. The next thing is let me check and see. Let's say that their sodium is normal. Okay, so it's normal. Or we check it and their sodium is elevated. If that's the case, then I don't want to give them this high concentration saline. So let's give me a lower dosage of the saline, or a type of saline called half normal saline. And this is half of 9, which is 0.45% normal saline. If I do that, I'm going to go ahead and give them 250 to 500 cc's per hour, and I'm going to give it of that half normal saline dosage. And then after that, we'll recheck. Let's say that I do that and their sodium is fine, but their glucose is what I'm worried about. And their glucose is a little low. Maybe it's like less than 250. And that's a little low, and I don't want to overcorrect their glucose and cause it to drop too low. So because of that, what I might do is I might give them 150 to 250 cc's of water. And what I'm going to do is I'm going to give them that half normal saline, so half normal saline, but I'm just going to add a little bit of glucose into it called dextrose. And I'm going to give what's called D5. So D5 is that dextrose, a little bit of sugar there, okay? And hope that that corrects their fluid abnormalities. The next thing is the insulin. We got to give them insulin to push that glucose into the cells. So when I do that, I'm going to start them off at a 0.1 unit per kilogram dosage, and we're going to do this as an IV push. So we're going to push this in. Then we're going to switch them to a drip where we keep that rate 0.1 units per kilogram of body weight per hour. What we'll do is we'll recheck their glucose. What you'll do is if the glucose is dropping, let's say that it drops less than 200 milligrams per DL on that glucose, then we might not want to give too much high dosage of that insulin. Let's drop the insulin dosage down. And they say do anywhere from 0.02 to 0.05 units per kilogram per hour. And then again, you can recheck. The next thing you want to remember is, okay, we correct the high glucose, we correct the dehydration. We also remember that we have that total body potassium depletion. On top of that, remember what insulin does. When we give insulin, it pushes the potassium back into our cells. So our total body potassium, yes, it might be low, but we might have what's called hypokalemia because we're pushing the potassium into the cells. So because of that, we might want to give potassium, but we base it upon their blood. So if we do a BMP and we get their potassium, it's less than 4.5 milliequivalents per liter, let's give them some potassium. Let's do 20 to 40 milliequivalents per liter of potassium and then recheck it after that. Problem is though, is if we give too much insulin and it drops our potassium too low, it pushes too much of the potassium inside of our cells, and the potassium drops to less than 3.3, let's stop the insulin drip. So let's discontinue the insulin for a little bit, and let's just go ahead and give them 20 to 40 milliequivalents per liter, recheck it, and see if then we can still restart the insulin. Okay? Last thing to remember is because this person can be acidotic, if the pH is less than 7%, severely acidotic, sometimes you can give what's called bicarbonate because it's a base and it's going to try to bring the pH back up. All right, engineers, so in this video, we talk about DKA and HHS. I hope this video made sense. I hope that you guys did enjoy it. If you guys did, hit that like button, comment down in the comment section, and please subscribe. Down in the description box, we'll have links to our Facebook, Patreon, and Instagram account, as well as our GoFundMe. You guys want to go check that out? We truly appreciate it. As always, engineers, love you, and until next time.